On this episode of Vital Conversations, a Doc Talk community series, Dr. Tamang sits down with Amy Iversen, CEO of West River Mental Health, to explore the evolving landscape of mental health in Rapid City and beyond. From shifting diagnosis to AI-driven therapy, they unpack trauma-based treatment, mental health tech, and how Monument Health can enhance local support. It's coming up on Vital Conversations.
How are you?
I'm good.
It's good to see you.
Yeah, you too.
The thing I really want to get across first is just the history and the nature of West River Mental Health. I think a lot of people don't have a sense of just how kind of historical of an organization it is and how big of a footprint that it carries in Rapid City and our community. Mm-hmm. Could you speak to that a little bit?
Yeah, so West River Mental Health really started many, many years ago with a psychiatrist who started seeing people, and it grew into an organization back in the 1960s. And so it formally became what's known as a community mental health center in the 60s. That's really when we were seeing deinstitutionalization as a movement across our country, where folks with mental illness were getting out of institutional care and moving into community-based care. And so federal government created this community mental health center concept, and West River Mental Health is one of those community mental health centers in South Dakota.
Yeah, and I think people are now sometimes regretting that deinstitutionalized nature of things.
Yeah, it's kind of the continuum of you're maybe swung too far one way and then you swing too far the other way, I think is what happened. And so I think now we continue to work to kind of get back to that middle of the road. Some institutionalization is necessary sometime, or that inpatient high-level care, but we want to serve people in community as much as possible.
Yes, and we encounter it so frequently where the degree of mental health results in a level of neglect, that self-neglect for the patient that becomes pretty dangerous. Trying to figure out where to draw that line from a committal standpoint is incredibly challenging. I imagine that's something that you folks deal with all the time.
Yeah, we really do, particularly in our program where we work specifically with people with serious mental illnesses. So those are the folks that are, they have those very intense mental health disorders like schizophrenia, bipolar disorder. Right. They have significant disorders and struggle in many aspects of their lives. And so, we do see that, where folks stop taking their medications and get to a point where they're not taking care of themselves, and there's this misperception, I think, sometimes that folks with these serious mental illnesses are dangerous. Well, they're mostly dangerous to themselves.
Right.
Not necessarily to others.
And for people that aren't aware, West River Mental Health has a number of programs that almost are like one-on-one with people, right? Like, so some of these folks that you mentioned with severe mental health disorders, which, I think the colloquial and not professional response would just be like crazy people that are out in the street. You actually have programs that really focus on them, people that track them down. I think it's the impact stuff. And,
yes.
And I think if you weren't here, we would know in a tremendous fashion. And it really does dovetail into what do you do with these folks? How do we solve that problem? And I know there's no easy answer to that.
Yeah, so our IMPACT program, which is a program that provides what's called assertive community treatment. It's an evidence-based model of working with folks with those serious mental illnesses and providing for their care on a day-to-day basis. It's very individualized, and so we can do not only the mental health therapy type things they might need, but those other pieces of assistance that they really need to manage their lives. So helping them take their medications. With some of our clients, we're going to their homes every day to deliver meds, do some symptom assessment and monitoring so that we can work on, are the meds working, what might need to happen with that, case management services to link them to other things that they need in order to maintain their lives, whether that's, helping with housing, food, kind of the full gamut of just those daily living tasks that we can help them with. And so those are very intense services, and then they can be less intense in some of our other programming for folks as they're doing better. And so, we have the luxury of being able to ramp up services when people need them, hopefully get them stable, and then pull back and let them kind of live their lives.
So in the 1950s or 60s, a lot of these folks probably would be in so-called asylums.
Yes.
I'm going to stop you just really quick. Sorry to interrupt. I just want to move you a little closer, Doctor. Just move the mic closer to you. Yes.
How's that?
Perfect.
Okay.
I mean, everything sounds good. I just want it to be spot on.
I appreciate it.
Go ahead.
So in the 40s, 50s, and 60s, a lot of those folks would be in asylums. But now the models that we do are sort of to employ these high intensity, assertive community health workers, or not community health workers, sorry, community folks, case managers, to try to mitigate their destructive tendencies. Is that right?
Yeah, without the services that we're providing in those programs, many of these clients would end up in high levels of care or incarceration.
Or jail,
right? Yeah,
Yep,
so
yep.
by getting these intense community-based services, we can keep them out of state psychiatric hospitals, for example. That's one of the reasons assertive community treatment was developed, is really to help folks not have to be in intense inpatient treatment, but to be able to be in the community with those very intense supports, day-to-day supports to help them maintain. And that's a great piece. It's wonderful for folks to have normal lives in the community and not be in institutional care.
Yes.
And it's less costly than institutional care. It's a high intensity program, but it's community based, and so it's obviously a lot less costly than having people in inpatient care.
Right. And just to frame it for Rapid City, we have a handful of these folks in our community. You have a better sense of the demographics than I do, but what I can tell you is that just a small percentage of these folks produce a tremendous weight on all of the emergency systems, the emergency department, the hospital, they are disproportionate users. So getting out in front of it is really important. And I think West River Mental Health's program in this regard is unique and one of the key features of our city that I honestly don't think people are even aware of. I think people sometimes think of West River Mental Health as, they have a clinic and people come there and they get, mental health assistance. Yeah. But in reality, you got people on the ground. You have people really trying to take care of some of these super high utilizers.
Yeah, absolutely. I mean, we have a full continuum of services. We have your typical outpatient therapy where folks come in and see a clinician, what I think the public generally views as mental health therapy and mental health services. And then we have this intense program for the folks with serious mental illness that I think you're right. The public doesn't really see that or understand that that's a piece that we do. And it is critical in keeping those individuals out of those other high-end services. So, without the contact with my staff, some of those clients would be calling law enforcement, calling 911.
Be in jail.
Going to the emergency room because they're out and maybe not taking care of themselves, and now they're, in danger of harming themselves because they're not wearing a coat when it's 20 below and, those kinds of things.
Mm-hmm. Give me a sense of how many folks you have working in that kind of space. And I know it's hard to know for sure, but like roughly how many patients you care for and kind of that high level capacity in Rapid City.
Well, we've got, looking at my numbers here since I brought them because I thought you might ask me that. Within that services to people with serious mental illnesses, we have two different programs. One is the IMPACT program, very intense, daily contact kind of thing. And then there's more of a step-down program that we call CARE. We served over 1,000 people in between those two programs last fiscal year.
Yep. And I can assure anybody, if they didn't serve those 1,000 people, you would feel it in the city.
Yeah.
Looking at the organization, it's hard to imagine if West River Mental Health didn't exist. It's hard to imagine making a proposition to say, hey, let's create this company, let's employ, quite a large amount of people, and let's take care of the mentally ill, and then let's stay in business. Mm-hmm. How does your business model survive? How are you able to balance those things?
Well, because we're an accredited community mental health center, so we work closely with the state of South Dakota to access some funding for those people, especially with serious mental illnesses that don't have insurance, can't afford to private pay. So we have some state contracts through that, and we're able to bill Medicaid for many of those services that we provide in those programs. So that's obviously very helpful for us in sustaining our model. And we balance that with all the other services we provide. So we're fairly large. We're the largest community mental health center in the state of South Dakota, and we provide a large array of services. So certainly our business model is helped by the outpatient therapy services we provide and some of those in-office type of services that help balance out kind of those out-of-office things that are more costly to provide, getting out into people's homes. Not only do we do that in Rapid City, but we're doing it out of our offices in Hot Springs and Spearfish, and then we're reaching out into most communities in western South Dakota. We serve a 10-county catchment area, so we serve basically the whole western side of the state is assigned to West River Mental Health as an accredited community mental health center, and I have staff going out into most of our communities for adult and children and youth services. So we're out in many of the schools in the communities. So there's a lot of travel involved. We put on a lot of miles getting out into those communities. So it's quite a large amount of things that we do and a lot to manage from a business standpoint. So it's fairly complicated, but
yes.
I think the organization is a strong organization. Like I said, they've been around for a long time. There's some benefit to being an accredited community mental health center and helping us sustain that model because we're one of 11 across the state, and so we work collaboratively with some of our other partners in that regard.
Give us a high-level overview, just for folks that might be interested, number of employees, sort of general ballpark statistics for the organization, just to give folks a sense of it, because again, I think it's a big unknown to a lot of people.
Yeah, I would say if we're fully staffed, we probably have around 180 employees within our organization. Most of our staff are clinical staff, and so that's mostly what we employ are those staff out working with clients. That's what we do. We have one of our largest programs is Pivot Point, so that's our crisis stabilization service that we opened up a couple years ago. And so when we opened that, our organization grew quite a bit because we had to hire a lot of staff and kind of ramp that up. So that's a really big piece of what we're doing today.
Yes, and important. So 180 employees working directly in mental health, largely in the Rapid City area.
Yep, largely in the Rapid City area, and then, like I said, we have staff in Spearfish and Hot Springs as well.
Yeah. Tell me about Pivot Point.
So Pivot Point is a crisis stabilization. It's accredited as it's called an appropriate regional facility. So the state of South Dakota a few years ago started looking at how do we provide care closer to home when people are in a mental health crisis, because what was happening is when people are in a mental health crisis, really the only option is inpatient psychiatric care, generally at the state hospital in Yankton. That model obviously doesn't work well for lots of places in the state, especially in western South Dakota, where Yankton is a long drive. And so many of those clients, as we researched that, we found out that many of the clients that were going to the state hospital were only staying for a handful of days, less than 5 on the acute units. And so it didn't make sense that we're dragging people clear down to Yankton. They're staying for a couple of days, stabilizing, going back to their home community. It makes a lot more sense to look at a model where they can get that stabilization in or near their home community. And so that's really what Pivot Point does, is we're able to take folks in a mental health crisis, stabilize them in a handful of days, and then if they do need longer-term care, we can get them to that longer-term care. And so I think it's been it's an amazing model for the state of South Dakota to have, and it's been wonderful for this community in particular in western South Dakota, where the resources are so far away from here. And so I think, in the 2 short years that we've been in operation, we've helped a significant amount of people, and it's easy to access. And that's one piece that I think is so important. Mental health services and finding what you need at the right time is difficult. It shouldn't be, but it is. And so with this model, anyone in a mental health crisis of any type can walk in the door 24/7, whether it's yourself or you're bringing in a family member who's suicidal, who maybe has stopped taking their psychotropic meds and needs immediate help, and you don't know where else to go. Come to Pivot Point. And so I say that repeatedly. If you don't know where to go or what to do and you're in a mental health crisis, walk in our doors. If we're not the right place, we'll get you to the right place. And so that's what I think is another piece that's really great about it is We provide on the front end, we'll do a mental health assessment, we'll look at what's going on with the person, and then make some decisions about, do they need to go into one of our stabilization beds? Do they just need to get connected to an outpatient counselor and get some services on an outpatient basis? We can get that set up. Do they need access to a provider who can prescribe some meds potentially to deal with what's going on? So we can really dig into what the problem is and get them connected to the right resource.
Pivot Point is something I've used professionally. I think it's a fantastic tool. It strikes me as you're almost taking a mental health hospital and boiling it down to sort of a short-term stay and then pivoting to where they need to go, which is quite an ambitious undertaking because there really wasn't anything like that before, as far as I was aware, and it's not a model that's super well understood. What was the challenges of building that out?
There's not a lot of this around the country, and so there was some work on the front end to look at the few models that are out there and learn from them. I think for us, I interacted quite a bit with the Human Services Center in a prior career before I took the position I'm in now.
We'll talk about that.
Yeah, so I had the benefit of really understanding the population that we were potentially looking to serve. I helped with kind of analyzing, looking at crisis stabilization services in South Dakota when I was working in state government. And so I came into this position with that knowledge, which was really helpful because I understood the types of patients that we were seeing at the Human Services Center that at that time I didn't want to see at the Human Services Center. I wanted them served locally. And so walking into this and being able to stand that model up has been really exciting, and not without its challenges, of course. And we're learning every day as we continue to serve folks. But I think the biggest challenge on the front end was just simply hiring staff. It was
hard.
Right after COVID.
Yep.
The workforce was just not there, not only, in hiring for a new program, but in our ongoing programs we were struggling. And so to stand that up during that time was extremely challenging. And we had to kind of take the model and tweak it a little bit. Kind of our expectation of what it would look like going in is not where we ended up. Just out of sheer necessity of needing to find a model that would be supported by the people that we could hire.
Yeah, I'm sure it was an emotional roller coaster from, I think, an outside perspective, from a professional point of view. It progressed nicely, and I think where it stands right now, it's the strongest I've ever seen it, and it's a really important tool. So I think people should recognize Pivot Point is a remarkable success. I think the Impact program, where you actually have case managers taking care of some of these people that otherwise would be hugely difficult to handle, is a huge success. So it's a different perspective on your organization that I think the other leaders that are listening to this would probably appreciate. You are their chief executive. You've been a chief exec for a couple of years. Is that something that you had ambition to do when you were working through your career, or how did that come about?
I certainly like working in the mental health field. I'm a counselor by trade and ended up in administration, not really expecting that to happen, I guess. But I really enjoy that work. As I work directly with people as a counselor, I really could see how systems weren't working well together, and I found it very frustrating. And so I ended up in state government and then suddenly had this opportunity to impact systems and how they work together. And so I kind of dove into that head first because I find that really interesting and challenging. And while helping people on a person-to-person basis is great, I find for myself helping at a level where you're impacting systems, then you're really impacting more people than you would just the number of clients you might serve in a day or a week.
Yes.
So I find that really interesting, and I spent over 19 years in state government working on kind of developing and enhancing the systems that serve people with mental health and addiction issues, and then had an opportunity to run a community mental health center in Pierre where I was living, and then the job out here opened up, and I was really interested in being involved in a larger organization, and this gave me that opportunity. So yeah, I didn't set out to do this. It just kind of happened that way. But it's been great, and the continuum of being in government and working on the programming and the funding and kind of all those pieces that go with it really gave me a unique, I think, perspective on now being a CEO of a community mental health center and actually running those services directly. I have a background that most people don't have because of my government work, and I think that does give me some ability to look at it differently maybe than other people would.
What do you think the most underrated attribute of a chief executive officer is?
I think it's, you've got to deal with so many different issues, complex issues, from kind of the finance of the organization all the way down to the service to the person. And I really think it's important to understand all of those components when you're running these types of organizations. I think if you don't, you miss out on pieces. Maybe you're financially sound, but you're missing the point on delivering service and how it's impacting people, or vice versa.
So kind of keeping a global oversight of the 10,000 things that are trying to kill you, or many things that are getting in your way.
Right.
Yeah. Yep. I think that would be shared among many of your peers is probably one of the more challenging problems. Where do you see yourself leading this organization in the future?
Well, I think, like I said, we're the largest community mental health center in the state. We serve the largest geographic region. I think as we move into the future, I want to continue making sure we're an incredibly strong organization and we're able to offer support to some of the smaller community mental health centers across the state too, that are serving small areas, with limited staff because they're in very rural places. I think as a larger organization, we can provide support to some of those places because I think as a system, we want all of that to survive and all of that to be there for the people that are struggling with mental health issues. So I really want us to continue that, being that leader across the state and being a strong agency in this community and region for the people that we're serving and the partners that we work with. I think one of the most incredible things we do is partner with lots of different entities in our communities in Western South Dakota, whether that's Monument or the city, the county. All of them are incredible partners for us in serving sometimes very challenging populations, and there's definitely overlap, as you know, with the people that we're all serving. And so I want to make sure that our organization continues to be a strong partner and a leader in helping determine what's the best way to serve folks with mental illness. And, I think there's other things we can do to address some of the gaps that we see out there. There's certainly gaps in housing, especially transitional housing. As we stabilize people at pivot point and they don't have good housing options, then we're discharging them to not good housing options, and then we expect them to be mentally healthy, and that's probably unrealistic. And so, I think there's work to be done there in the coming years, and there aren't easy solutions, as you know, related to that. But, I think by working together with our partners, we can figure those things out, and we can each pick up pieces to make that system of care stronger for the people that we're all serving.
So obviously you operate within the structure of a city and many other municipal and state codes. As far as the way the city interacts with mental health, do you feel like the housing shortage or issues of that nature are the biggest detriment to kind of getting your folks on to a more stable position? Or if you had to kind of teleport yourself into city leadership for a day, what are some of the things that you think, it would be great if we could kind of work on these areas?
Yeah, I think housing is one of the key ones, and big shock, like everybody who works in these fields and with folks that we all interact with say housing is a challenge in this area. I think it's a challenge across the country, so it's not unique to South Dakota or even Western South Dakota, but I think we face some issues with it that maybe not all communities face in regards to, the cost of living in western South Dakota is higher than other areas of the state, and housing is more difficult to access because of that in western South Dakota, just with the influx of people, I think, and the changes that we're seeing here.
And you have real-time data with your folks that are working with people trying to get into housing, so you're actually not just looking at it from a high level, you're looking at it as like, hey, Fred is trying to get into housing.
Exactly.
He's trying to get this voucher. We can't get a voucher, then we got to go hunt for a spot.
Right.
And so you encounter the practical issues of it too. This is not a easy question, and there's probably not a right answer. But how do we even begin to work on the housing issue? How does the city, are there any other models we can look at, or is there anything that can be done to try to, when you look at nationally, there's kind of these housing first initiatives, which they're a mixed bag, obviously, but the idea behind them, I think, is good. If you want to be housed, that's the first thing.
Yep.
It's awful difficult to work on kind of your mental health piece if you're not in a stable environment. So I don't know. Any thoughts there?
Well, if I knew the answer to that, I probably wouldn't be sitting here. I'd probably be rich and on a beach somewhere.
Right.
I think it is so complex that there's not one solution that's going to fit everything, obviously. And so I think you really have to target your solutions in areas where you're going to get some bang for your buck.
Yes.
Like you said, you don't want to run around chasing people who don't want to be housed in the first place.
Right.
Because you'll house them for a period of time. That will end, and they'll go right back to what they were doing before.
We've seen that over and over again.
Exactly. That's a waste of resource. So to me, we've got to target our housing initiatives and our housing strategies to people who maybe are going to be successful in housing once we go through all that. So I really think looking at smaller subsets of the population that needs better housing options. For example, folks that are in Pivot Point, we're stabilizing them there. Let's look at housing options for some of those folks as they're discharging so that we can work on their mental health issues and addiction and whatever else they have going on. Because you're right, if they're not housed, they don't have food, they don't have those basic needs met, none of the rest is going to fall into place.
Right.
And so are there strategies to target some of those folks that we think that do want to be housed and want assistance with that? Let's get some transitional housing for them, begin building that, teaching them to live independently, because some of them need that. They need just basic, how do I live independently? How do I make meals, budget, all those components. And those are things my agency can provide to those clients and help them learn those skills. So to me, it's really looking at that and then, getting them into that transitional housing for a period of time, teaching skills, helping them save some money so they can afford security deposits and, all those things that go with being housed, and then get them into more independent housing. So it's more of a continuum. It's not a here's your housing, now we're done. That's never going to work.
Just the first piece.
Right. How do you develop that continuum, I think, is what's important.
Yeah. And for folks that are working on this problem, it's also interesting to think about, so you have an unhoused population that needs help, obviously, but then there's folks that are on the verge of losing housing, and how you prevent that from occurring is possibly a higher yield area. And I would love to see more emphasis on that. How do you do that without it getting scammed? How do you do that in a reasonable way is very difficult, but I think that's an area that would be exciting to work on.
Yeah, and we do that every day. I have staff that are out working with folks to maintain their housing, and so that's part of what we do in our impact and care programs is, having conversations. You have to clean your house. You have to, maintain it.
Pay your rent.
Or pay your rent, or you're going to get evicted.
Right.
And so working with folks on that, and my staff are very skilled at developing relationships with landlords. And so we're communicating with the landlords to say, hey, we know this is an issue. We're here. Call us if there's a problem. So we can try to also advocate for our clients and intervene as much as possible. Obviously, people make their own decisions, and, we're not guardians of these folks or anything like that. So sometimes they make bad decisions and, people get evicted. But we work really hard to try to keep them housed once we find housing.
Yeah, and there's so much subjectivity to it as well. I know in the various programs that I've worked with, intermittently, someone will pay someone's rent for a month or two. Like this happens. It's often not a systems-based solution, though.
Right.
It's often just the organization decides to do it, but quite frequently the workers decide to do it. because they see the detrimental effect. It would be lovely to find a systems-based solution.
Mm-hmm.
I don't know if one's possible, but maybe somebody smarter than me can figure that out. The other topic to bring up on this issue is there's been a bit of a rise in Oxford houses in the area. I'm not sure if you've seen that, but I think there's 5 or 6 now in our city, and they're run obviously by sort of a national organization, but they have some, and again, there's some people that are a fan of these, some people that aren't. Mm-hmm. But as a general sense, they do provide housing and built-in sort of peer support. Mm-hmm. And so there's definitely a place for them, and it's exciting to see that rise because it's a very kind of a well-known system. And the people that go through it, they tend to have very high rates of employment afterwards. It is self-selecting, obviously, it's a little local political group.
Yes.
But for people who aren't aware, I think the Oxford House model, and there's a few others that are sort of similar, that's something that I think plays a role in this too.
Yeah, I agree. And I think, you need a variety of different options.
Yes.
Because one option might work well for one person, but not for another. And so you need, peer supports work great for many people, and that's a great avenue. Not for everybody, though.
Right. The other system that obviously I want to talk about the interaction with is Monument Health. Mm-hmm. We have, the behavioral section of our organization. How can we do a better job with mental health, coordinating with West River Mental Health, just in general? What role would you see us performing? Well, maybe you can sandwich it, maybe something good and something.
Well, I think, we certainly interact with different components of Monument Health, especially with Pivot Point.
Yes.
We're hopefully taking pressure off the emergency room by, getting people to Pivot Point so they don't have to go to the emergency room.
Or taking people from the emergency room so they don't have to go to the hospital.
Yeah, exactly. Yeah. So I think, that relationship has been really important, and we work hard to be good partners with the emergency room. And, they've been very good about, when we see challenges or things not working quite right, really, getting the right people to the table, having those conversations. I think that's important. It's, being able to communicate not only and be happy when things are going well, but also be able to communicate and say, hey, this didn't work so well on whichever end, right. And look into, hey, why did this happen? How do we do a better job? And then with the inpatient facility, Monument West, certainly we also interact with them, and that's a critical piece because they're a direct component of that continuum of care,
yes.
Especially for us at Pivot Point, and even for folks who don't necessarily go to Pivot Point who just need inpatient psychiatric care, because sometimes people need that. Mm-hmm. And so, that's another important connection for us, and, we work regularly with the folks over there at West to,
yes.
Share information on clients and, make sure we know when people are going in and out of care, so that we're, prepared when they're being discharged, and so that people don't fall through the cracks and that kind of thing. So I think it's just that ongoing communication and recognition that we're all doing the best we can all the time. Sometimes things don't go as planned, but let's get together, have the conversation, and look at how we can do better next time when those things don't go well.
There's a lot of talk about having worked for Monument for 11 years, I've heard a lot of various ideas pitched about like how to provide better mental health. And then anybody who's gone deep into it, they realize, gosh, this is difficult. Mm-hmm. This is extremely challenging, which is why, your organization is commendable because it's survived in this landscape, solely in this landscape. Mm-hmm. And some of the things, that have been innovative, I wonder if there's anything that our community has that you've read about, seen elsewhere, that, gosh, this would be nice to have in our city. Like some of the things that I've seen are the idea of acute urgent cares for mental health, which is kind of like Pivot Point, mm-hmm. but more of a like stabilization and discharge kind of thing, the same day, like an urgent care. Mm-hmm. I don't know if that's a good idea or not, but that's being run in certain places. Is there any infrastructure from it's more of a health system or a standalone health structure that you've seen that you think, gosh, maybe that could be worth a try?
Nothing in particular that I've seen that you look at it and go, wow, that solves our problem here. I haven't seen anything like that. I think a lot of what we're doing and can continue to do and continue to grow out, I think will become that for this community. I don't think there's anything you can go and pick up and bring in. I'm just not a big fan of that. I've seen it done and I've seen it not work very well.
Sure.
And so I think it's far better when you get local people together, the agencies and the folks that are interacting.
Yeah. You mean hiring a consultant to come in and solve all your
yeah,
problems?
really
that
not a
didn't
fan.
work every
no,
time?
It doesn't usually work. They have
They give you nice sheets, though.
Right, they
and
give
yeah,
you great reports, and you can put it on a shelf
Right.
and say you did that. Certainly outside people can bring ideas
Yes,
forward, but
yes.
it's really the people in the middle of it day to day that know what the problems are and can figure out solutions. And sometimes, you have knowledge of different things that are going on in other areas, and you can pull pieces of that. And I think Pivot Point has become that, where we pulled pieces from other programs and ideas that are out there in other states and kind of fit it for Rapid City in western South Dakota. And I think as we continue to do that, we're only 2 years in, so we're babies at this right
Yeah.
now. I think as we continue to serve folks in that model, we're going to learn a lot more about, other components of it that might be helpful, like a more of an acute, we do a assessment on the front end that does a little bit of that, but is there more of that needed? I don't know, maybe not. And so I think it's important to think about that so that you don't build something that either doesn't really fit your community or you never needed in the first place.
Right.
And so I think,
Tailored solutions.
Yeah.
I suspect your work in government kind of helped you see implementation on a systems-based strategy, and certainly working, because government often doesn't do it themselves, right? They bring in people or empower groups. I imagine that helped a lot as far as not falling for certain sales pitches and being able to understand, how things can be built organically from the ground up.
Yeah. And that's absolutely true. I understand system work. I understand how it doesn't work, what doesn't work. And so I think that knowledge helps me in this role, and I think will help as we continue to grow what we're doing at West River Mental Health. I think there are other components that we can do into the future, but we're not ready for that yet. I have lots of ideas of things we can do. I tell them to my staff, and they probably feel panicky as I, have big ideas about kind of what we can do and what the needs are. But we need to do it slowly. We need to walk forward and challenge ourselves to look at what we're dealing with today, and then what is the next component to deal with the things as we find them, so that we're not just jumping ahead to something that isn't a good solution.
Yes.
Sounds maybe good, but really isn't.
And I think one exciting aspect that I've learned so far in my career is when we're building organic programs, new leaders emerge from within our community. So, for example, you're a CEO here. You grew into that role by being an actual, a counselor, right? A professional. That was your training. That kind of thing brings a depth to the community that I don't think you get when you hire a consultant from Los Angeles to come in and solve your problems and produce a nice KPI dashboard.
Right.
Yeah, so that's something I think we all should keep in mind. Looking forward a little bit in terms of where mental health is going in general, it's there's kind of like this dichotomy where we see the diagnoses like going through the roof. Like it seems like we're all more mentally ill if you look at the numbers. Right. But then there's a lot of really amazing technological and pharmacological breakthroughs that are happening that seem to be promising. What's your general feeling on the outlook for our community, for our country, in terms of mental health?
I think we're in a great spot right now when it comes to mental health, acceptance of mental health disorders and willingness to get treatment for those disorders. I think we're seeing a change where, there's always been a stigma attached to mental health. Nobody wants to admit, gee, maybe I'm struggling with some mental health issues. Let's pretend like we're not. And so I think we're seeing a move where people are more willing to say, yeah, people have mental health issues just like they have healthcare issues,
right.
Physical healthcare issues, diabetes or, heart disease or whatever it might be. It's just another issue that people have, and it's okay to say I'm struggling and I need help.
I feel that too. I feel like stigma is definitely getting better. One aspect that I think a lot of these organizations like the DSM-5 and the ICD, those are, for folks that don't know, those are frameworks that clinicians use to diagnose people with various conditions. They've tried to get more encompassing. Mm-hmm. And I think as a result of that, we've seen a lot more diagnoses mm-hmm. of certain conditions. And so there's a plus and a minus to that. Do you think, based on what we know now, that we are in fact seeing more episodes of ADHD or bipolar, or do you think that we're just capturing stuff that was always there, or do you think we're so-called pathologizing normal behavior?
I don't think in general we have more mental illness than we've had historically. The 1 in 5, the 1 in 5 number that's been out there for many, many years.
Yes.
1 in 5 have struggled with some level of mental health issue in their life. And that hasn't changed, at least not in the data I've seen. And I don't think it will change significantly. I think there's more awareness
yes.
and more willingness to talk about it, to diagnose it, to get treatment for it. So it seems like there's a lot more, but I think it's probably, about the same as it's always been.
Yeah.
I don't think we're seeing some big, huge spike in mental illness in this country by any means.
It feels almost generational in a way. It seems like younger folks are much more willing
yes.
to describe their struggles with this sort of thing, which is gret progress, right?
Mm-hmm.
That's amazing. And that is booming into some new elements of treatment as well. Therapy. Let's talk about therapy for a second. When people hear therapy, they think of all sorts of different things. Give me your high-level overmap of, what therapy is.
I think, people mystify it and, they're going to do something to my brain and, this is, voodoo type stuff. I think people sometimes have that perception or they attach it to things they've seen on movies or, that kind of thing. And really, therapy is just the opportunity to talk to someone with some knowledge and some expertise in what you might be struggling with, be that anxiety, depression, those life events that we all have and we all struggle with at times. But for some folks, you get to a point where you're not functioning very well anymore. And then it's time to go talk to someone about it and really figure out what's going on. Are there some strategies that can help you deal with whatever it is in your life? If you've had a major life event like a death or a divorce and you're really finding yourself struggling where you're not doing those day-to-day activities anymore and you're, not getting through it, then it's good to talk to someone about that and get some help and some strategies.
For sure.
And it's that.
Yep.
And then looking at, what else might you need along with that? Are there medications that can help? Is there a referral to a provider that can look at that? So, and I think those two things together are generally effective. You see, this increase of awareness in medications that can help with mental illness, and especially in today's world where, all the advertising that happens from the pharmaceutical companies and whatnot. This belief that maybe there's a magic pill, my life isn't very good and I'm not very happy. What's the magic pill that's going to solve that for me? And there's not one.
Right.
And so it's really, therapy can be a really important component of getting the help you need, even if you maybe are also taking some medications to help out with that.
Yeah, and trends in therapy, I think, is a really interesting thing. I'm curious your thoughts. I think a lot of people historically think about, kind of old talk therapy where you kind of go back and you go through your whole history.
Dredge up your childhood and what happened to you that made you this way.
Laying on a couch kind of thing.
Right.
And most of us that work in the field realize that it's much more practical, cognitive behavioral therapy.
Yes.
And I think that's proven to be very beneficial. But there's some new kids on the block that I think I'm interested to get your views on it, and that's the use of psychedelics. This is making a big push in, I don't know if I would say established channels, but I mean there's some very reasonable organizations that are looking into this now. Mm-hmm. And I think just to lay out the framework, the idea is that there can be memories or traumas that are unprocessed, and utilization of a psychedelic can cause the brain to, in some manner, deal with them, reorder them. And so many patients have shared experiences. They're always more affluent because they're able to go to these places that's basically like med spas sort of thing. And then they go through this process, and they typically I've found a positive story. Maybe that's self-selecting and they're telling me these things. But do you see this as a trend? Do you see this as valuable? What's your thoughts?
I don't know a lot about it. I know it's kind of out there, and there's some success with some folks that are going that route. So I don't have strong feelings either way about it in particular. But in general, I think, we have to be open-minded about what will help individual people, because one size doesn't fit all. And so, I think exploring all options of ways that we can help folks, especially deal with trauma and some of those things that can be really debilitating for the people that are struggling with those types of issues. And so, maybe that will be one avenue at some point. I think it's certainly worth more research and study to see what the opportunities might be. But I think always being open-minded to what's out there. We do different types of therapy related to trauma with folks that probably when it started, people were like, wait a minute, that's
Tell
weird.
me about that. That's as interesting.
EMDR is a
Yes.
particular approach for dealing with trauma that, I suppose when that first started, people might have thought
It sounded crazy, right?
Right. People might have thought it was crazy, but it really works well for people. And so I think you can't just shut the door on it and say, no, that's out there. That's never going to work.
Yeah. And so for folks that aren't aware of that last point, there's kind of a theory behind a lot of mental health that it could have been caused by trauma. They call it trauma-informed mental health. And they some way discovered that if a therapist was able to get a patient to be focusing on that particular trauma or situation, and then they perform some form of bilateral stimulation, which is the therapist would make the patient move their eyes to both visual fields. Sometimes they'll have these sticks in their hands that vibrate on the right and left, or sometimes the therapist would tap their knees, that it caused the memory or the trauma to become desensitized. And it sounds nuts, right? But the data and the outcomes for that were quite strong.
Yes.
So I imagine that's something that you folks do to this day on a pretty regular basis.
Yep, we have staff trained in EMDR and do that for folks to deal with trauma. And we have some other types of trauma work that we can also do that's similar to EMDR but not quite the same. And so, that's a piece that we really work hard to stay on top of and make sure our staff have those tools when they're working with people. Because therapy today isn't, lay on the couch and talk about your childhood and figure out what happened there that made you all messed up. But it really is, it's intended to be focused, brief. You shouldn't do this for the rest of your life. We want to help folks deal with whatever challenge they have going on and use strategies that have some research behind them and have been shown to work, not just you're just going to come in and talk for 10 years about your childhood and all the other problems you're having.
Be embarrassed and pay your copay.
Right, exactly. So, we really want to do brief strategic work that helps deal with the issues and gets the person to a level of functioning again so they can get back to having their life.
Something I worry about that I think I was totally blind to just a few years ago is sort of the idea of kind of cultural-based treatments. And I think the argument is that mental health has been categorized from a very Western approach. And at first, I just kind of gloss over this. It's like, well, it's because we have evidence and thought process. But there's actually, I've learned it from my profound ignorance before, there's actually a lot of cultural bound syndromes that are based on long-term oppression, various societal traumas. And so when you look at some of the, and psychedelics play a role in this in certain groups as well, but things like, there's cultural things like sweat lodges and talking circles and, all of these elements that you're not going to find them anywhere in any treatment modality. But being culturally sensitive, I have learned it's not about PR. It's actually a very legitimate thing that is important to incorporate. I'm sure you folks are doing that as well.
Yeah, it's absolutely critical. And, I think we try to do a good job of linking people to kind of those other providers that can do some of that cultural work, whether that's the Sweat Lodge or, those other things that can help individuals, especially our Native American cultures. And so culture is important. It's important across the board, and we look at it really broadly of every person coming in has their own family culture, and, we have a West River culture.
Right.
There's just so many things that play into that. And so we work really hard to try to individualize everything we're doing with every client, knowing that culture and a lot of other things impact them and have to be taken into consideration when we're working with them.
Yeah. And then going back to the fact that we're all humans, pharmacology is evolving. And one area that, as an addiction medicine physician, I'm getting asked about all the time are these GLP-1s, the meds everyone's taking for weight loss. There is a pretty profound wave of papers saying that they help with substance use. I don't think it's been concluded yet, but it seems to be going that way. And it also seems to be going that way for mental health. Those studies are starting to go as well. So I wouldn't draw any conclusions. But I would say I've had a lot of patients now anecdotally tell me it's helped tremendously. So again, I wouldn't commit to saying this is the way to go, but I would say based on like many anecdotal stories that I'm seeing and the fact that it helps with food addiction,
right.
I'm curious to see how GLP-1s affect addiction and mental health.
Yeah, I agree. And I've heard some of the same things in regards to, because it helps with food addiction, it can help with other addictions, and substance use disorders certainly come to mind then. And, those are hard disorders for folks.
Yes.
It's cyclical and there's relapse, all of that, as you well know, is part of the process. And, I'm really excited to see what the future is going to hold related to that, because if that does indeed help folks who are dealing with substance use disorders, then what a great tool.
Yes.
In helping them manage it day to day, because that's tough. It's a daily struggle. And
yep. I remember the first time I started kind of thinking about this seriously, a colleague of mine was prescribed a GLP-1 for weight loss. He lost a ton of weight, by the way. But he also quit smoking, and he stopped drinking 6 cups of coffee a day.
Wow.
And I was like, why did you do that? And he goes, he didn't have the desire to do it.
Yeah.
And now subsequently, I've just noticed that. And I think the influencers have noticed this too. Sometimes they're out in front of us, and sometimes they're right. Sometimes they were very wrong on vaping. Like that.
Got that one wrong.
Yeah. There's like elements of truth to stuff, but they're very much talking about this. Like, if you're on social media and you kind of pay attention to these forums, which is always sort of questionable mental health to begin with, the GLP-1s are all over, and they're getting compounded. And I think it's worth looking at. GLP-1s have very low side effect profiles. I wouldn't recommend doing things that didn't have doctor supervision, but it's very interesting in the future. And there's other cool things. I mean, not just from a pharmacologic standpoint, but from a technological standpoint. I am one very much waiting for my robot replacement to come into the hospital and start taking care of patients with superhuman intelligence, and I can just supervise and make sure they're not. But I've noted quite a few mental health chatbots that are popping up. And in fact, some of these have FDA approval for certain applications. There's one that's pretty popular for cognitive behavioral therapy for sleep issues, which is a huge problem. CBT for sleep is one of the gold standards, but it's super hard to get patients to a counselor for that.
Right.
So I know they have a role. I'm just not sure how deep that role is going to go and what the timeline is on that. It's kind of exciting, a little scary, but kind of exciting.
Yeah, I agree. I think, it probably holds some promise for the future of mental health care, but then the other side of the coin is there's some concerns there for, harm could be done to people,
Sure.
So that's certainly the thing that I think has to be figured out, is how do you use that in a way that does advance the field and help meet the needs of the folks that need that care without doing harm.
Yes, yeah. It's interesting because, well, I'd be interested in your perspective. Do you feel like the access for a highly skilled counselor is accessible to most people? I think we're not in a terrible spot in West River, but I do think there's some folks that, they're just trying to kind of keep their lives together. They can't necessarily facilitate, the executive management of their life to get to a counselor, whereas maybe a tool like, a bot that happens to express a lot of axiomatic thoughts that are, relatively benign, and then in the future, maybe even, a very smart bot. It could be useful. I don't know.
I think it could. I think especially as you think about that initial access into care, like you just said, for people who maybe aren't going to get themselves somewhere to get help, don't even know where to start, don't have the ability to figure that out at all. If there's a way that we can interact with some of those folks with some initial screening type applications, identifying the issue, some of that front end work, I think there's some definite promise there. But then also knowing when do you really need to connect with an actual human.
Right.
I think we do. Access is always going to be an issue for various reasons, especially in a state like South Dakota. But I would say for my agency right now, we are closer to being fully staffed than we have been in many, many years. And
Very
so
good.
we're in a great spot right now where we can get pretty immediate access for folks walking in and needing some outpatient counseling services.
Yes.
So, I think, we're definitely better than we were 2 years ago when I walked in the door for this position. We've staffed up, and I think a lot of that has to do with just the world in general and people getting back into the workforce. I think having enough counselors in the field, therapists, that's probably an ongoing problem, just like many fields, psychiatrists and, lots of different areas. So that's not solved overnight. But I think we're moving in a better direction than we have been for the last few years. And so I think that's promising and that's good.
Yes.
So I think how do you balance, using technology in some aspects of it, but also having those folks that can provide that actual care, human to human.
If we can reduce the stigma to a degree where people are comfortable going and the access is there, that's obviously the goal. I was watching a medical presentation for Apple's Vision Pro, and it was helping a surgeon do this, complicated case. But then they also talked about virtual reality for mental health, and I thought, well, that's pretty fascinating, where someone could put on a Vision Pro, enter a virtual world with a counselor and several kind of AI-assisted, bots. So, theoretically, you would meet with your counselor, then you would get your session by some programmed, thing. And it described a model where the cost would go down, the human would still be involved in a hybrid approach. And I have a feeling that's the way that it's going to go. I don't think the human will ever be out of it, but I do think it really could open up the world to a lot of people. And a lot of people, and I tell people, I bet on a weekly basis, I bet I have at least 15, 20 folks I'm trying to refer to substance, or mental health. And a lot of them, it's just not in their priority. They're at the base triangle of, Maslow's hierarchy. They're at the physiological needs stage.
Right.
They're not at the, a self-actualization piece,
Right.
So for them, they're thinking about their rent and they're thinking about, food and things of that nature. So any sort of access from that, it would be fascinating. Do you see that coming, or do you think that's really far off?
It's probably closer than we think, just with the way technology is moving. It seems like things are changing every day. And I really look at it like, back before we did telehealth. I remember the front end of that where it was like, telehealth?
Right.
You can't do therapy without being in a room with people.
Yes.
Oh, the horror of that. So I
right.
really look at it like that. And that was just a few short years in the past, where people were really up in arms about this. And now We do it all the time.
It works.
Regular.
Yeah.
It's regular.
Patients love it.
Patients love it. Clinicians have learned to do it and like it, and it's effective.
Most of them.
Most of them, yeah. And so, but also it doesn't work for everybody.
Right.
And so it's that
hybrid.
balancing. It's that hybrid approach of how do we use it as a tool to help where it can help, but recognize it's not a magic solution. So I think, that stuff is going to probably come at us pretty fast and furious in the coming years, and we need to be ready for it and have an open mind. You can't just shut the door to it all and pretend like it's not happening, because it is.
Right.
So,
right.
How do we move forward and recognize the pieces that can really work, and how do you keep that actual person involved, that clinician, because I think, like you've said, that hybrid approach is probably where we're going to end up.
Yeah, I have a feeling it's going to get built, so we need the right people putting in input on how to build it. And then I think the other piece that this conversation must include is social media. I think we've had a pendulum in social media where it was super awesome and connecting people, and then it became, this is horrible for everyone's mental health, and all suicide is because of social media. And now I feel like we're kind of getting to this critical media literacy discussion where it's like, we need to be able to look at, especially with AI now, we need to be able to look at media and understand that it's not necessarily real, that it's more of a highlight reel of someone's life,
right?
And it shouldn't affect the way you view yourself. And I think, again, unfortunately, the older generations tend to have a lot more trouble with this, and I'm sadly starting to roll into that. But I don't know if you've seen what your view is on social media, how it can be a good, how it can be a negative. What's your thoughts?
Yeah, I think just what you said, it's positive and negative. Certainly there are aspects of social media, especially with our youth, that can be incredibly negative and damaging to their mental health.
Yes.
That can lead to mental health issues, addiction issues, because of some of what they're seeing and expectations of how life should be that aren't realistic. The influencers out there, so I think there's certainly aspects of it that are concerning. But then on the other hand, there are aspects of it that are wonderful and that can be used as tools to help us reach those populations.
Right.
How are we going to reach the youth? Social media.
Yes, absolutely.
They're not watching the news. They're not reading a newspaper.
Right.
What is a newspaper?
Right.
So,
yeah.
I think the way that we can interact with them and engage them into some of those kind of preventative messages too, of good mental health care and taking care of yourself and things to watch for, and kind of those types of things.
Does your organization do any campaigns on social media for awareness, or is that a space you try to stay out of?
We're not doing anything directly. We're certainly attached to some of the stuff the state government does, because we are a community mental health center. So as some of those messages are pushed out by state government, we're linked in as, hey, go to this agency if you need help, kind of a thing.
Yeah.
So indirectly, yes, we're involved in those. I think that's something that I really want West River Mental Health to begin doing more of locally, though, is more of that messaging and awareness so that people know who we are, what we do, so that they're know that we're here. I think there's a lack of awareness across Western South Dakota about who we are and what we do. Maybe they've heard the name. Well, they've heard the old name, Behavior Management Systems.
Right.
Of course, we changed our name.
Yes.
But, BMS, I maybe heard of that, but I don't know what they do.
Right.
So you're going to see us in the coming years try to do more in that area to get messaging out there and get us kind of connected to social media platforms, things like that, where we can push some of that messaging out. And we are on, we're doing a Mental Health Monday on the news. So we're out there on the news every Monday sharing
Excellent.
Information with the public about just a range of mental health and substance use kind of messaging, really general, but things that people should know and hopefully find interesting. So that's one piece that we've begun doing, and that we've done it for a year, and we're going to continue doing it into 2025. So we're excited about that. And then we're looking kind of for some other areas where we'll be able to get some messaging out to the public.
For any diehard folks that are still listening at this point, the
I feel bad for them, but
me too a little. No, this has actually been fun. The name change. Tell us why. I mean, I think it makes sense. I think it's much more encompassing of what you actually do. But what was the rationale there?
Well, when I started, I really felt like behavior management isn't what we do. While that certainly kind of was the trend back when that name was adopted, it was kind of where the world was. It's not where we are today. And so I felt pretty strongly that it's hard to do what I just described, the things that I want to do related to getting us out there and being an okay place for people to come. How do you do that when you're come over to behavior management systems and we'll manage your behavior,
right. Yep,
and that's not what we do. And so I really felt like, we need to take a look at a name that tells people who we are and what we do. And so as I started having those conversations with the board of directors, we really started talking about, well, the history of the organization is it was West River Mental Health Service. And so it's like, well, we are mental health care, and we do serve West River. So we just decided that, well, let's go back to our roots and go back to West River Mental Health, kind of drop the services piece. But so West River Mental Health it became, and I think it's okay to say we're mental health. We're doing mental health care. We can say that now.
Right, now it's good.
It's good now. So,
well, I think it's very fitting. I'm very grateful for your organization and your leadership, and thank you for having this conversation.
Yeah, thank you. I appreciate you asking me to come and join you and have the conversation.
My pleasure.